nursing care of immunologic, shock, and respiratory problems. The term SIRS has routinely been associated with sepsis, autoimmune disorders, pancreatitis, vasculitis, thromboembolism, burns, or surgery. SIRS was previously defined as 2 or more abnormalities in temperature, heart rate, respiration, or white blood cell count. When SIRS is suspected, it should prompt an evaluation for a septic focus. Sepsis causes complex dysfunction in the body's inflammatory and coagulopathy pathways, leading to vasodilation, vessel leakage, and increased metabolic demands. This effect increases oxygen demand, which combined with the intravascular losses causes hypoperfusion and ischemia at the cellular level. In a patient with sepsis from a urinary tract infection, some changes to renal function might be expected, but not abnormal blood clotting or lactate levels. Low blood pressure and dehydration is commonly seen in patients with sepsis, but will generally respond to fluid replacement. Patients with severe sepsis who do not respond to this treatment are considered in septic shock. If not actively managed, this leads to refractory hypotension, tissue ischemia, circulatory collapse, and multi-organ failure. So management is to deliver high-flow oxygen, test those blood cultures, administer the antibiotics, measure serum lactate and do a complete blood count, start intravenous fluid, and record accurate urine output measurements. Severe acute respiratory syndrome. This is a viral respiratory illness. Initial signs and symptoms begins with fever, overall feeling of discomfort, body aches, and mild respiratory symptoms. After 2 to 7 days, it leads to a dry cough, progressive hypoxemia, which then can lead to pneumonia. The mode of transmission is respiratory droplets. When an infected person coughs or sneezes, it is spread by close person-to-person contact. The droplets get on another person's mucous membranes or on a surface that is touched by another, and then they touch their own mucous membranes. Treatment would be the same for a viral pneumonia. Infection control would be to limit the transmission, so negative pressure rooms, protective equipment, and good hand washing. Prevention includes avoiding contact with those suspected of having SARS, traveling to countries or outbreak of SARS, close contact with crowds in areas where SARS exist. Legionnaire's disease is a form of pneumonia caused by Legionella pneumophila. The assessment is 1 to 2 days of prodromal symptoms followed by high fever, dyspnea, vomiting, diarrhea, confusion, and elevated white blood count. Interventions are to administer antibiotics as prescribed, supportive care including respiratory support, nutritional support, and fluid and electrolyte management. Histoplasmosis is a pulmonary fungal infection caused by the spores of Histoplasma capsulatum. It is transmission by inhalation of spores commonly located in contaminated soil. In the assessment, you would note dyspnea, chills, fever, possibly chest pain, elevated white blood count, positive skin test for histoplasmosis, a positive agglutination test, and hepatosplenomegaly. Interventions are to administer a fungicidal medication as prescribed, place the patient in a semi-Fowler's position, and monitor for nephrotoxicity from medications. Instruct the patient to spray the floor area with water in order to keep the spores down before sweeping a barn, chicken coop, or other potentially contaminated areas. Sarcoidosis is presence of epithelial cell tubercles in the lungs. Nursing assessment could see the patient with night sweats, fever, weight loss, cough, skin nodules, polyarthritis. A CAVEM test causes local nodular lesion in about 1 month. Administer corticosteroids to control symptoms as prescribed, monitor the temperature, increase the fluid intake, provide frequent periods of rest, and encourage small nutritious meals. Tuberculosis. Highly communicable disease caused by the Mycobacterium tuberculosis. Risk factors are alcoholism, drinking unpasteurized milk from an infected cow, and patients who are homeless and from lower socioeconomic groups, crowded living conditions, intravenous drug uses, and malnutrition. Transmission is airborne route by droplet infection, and after an infected individual has received tuberculosis medication for 2 to 3 weeks, the risk of transmission reduces greatly. The disease progression is that the droplets enter the lungs and the bacteria from the tubercular lesion become encapsulated. If encapsulation does not occur, bacteria enter the lymph system, causing an inflammatory response. Primary lesions may become dormant but can be reactivated, leading to secondary infection. Review the patient history. Was there past exposure to tuberculosis? A recent history of respiratory influenza? Previous tests for tuberculosis? and recent bacille calmette-guerin vaccine. The clinical symptoms are fatigue, lethargy, anorexia, weight loss, low-grade fever, chills, night sweats, persistent cough with production of blood-tinted sputums, and the chest feeling tight. A chest X-ray is not definitive, but presence of multinodular infiltrates with calcification in upper lobes would suggest tuberculosis. A quantiferin TB gold test is a blood analysis test and is sensitive and rapid and assists in the diagnosis. The acid-fast smear identifies tuberculosis, confirming diagnosis. After medication is started, the sputum samples obtained are used to gauge effectiveness of the therapy. If there is a positive reaction to the mannitol tuberculin skin test, it does not indicate active disease, but exposure or presence of inactive disease. When the result is positive, it will remain positive in future tests. The area of induration, measuring 10 millimeters or more in diameter, 48 to 72 hours after injection, indicates exposure to tuberculosis. For individuals with HIV infection or who are immunosuppressed, reaction of 5 millimeters or larger is considered positive. When the skin test is positive, a chest X-ray is necessary to detect active disease or old healed lesions. The hospitalized patient must be in respiratory isolation in a negative pressure room. The nurse must wear a particulate mask. If patients need to leave the room, they must wear a mask. Patient education is to instruct them to follow their medication regimen as prescribed. The need for adequate nutrition, a well-balanced diet, instruct the patient to cover their mouth and nose when coughing or sneezing, and dispose of tissues in a plastic bag. The patient will need to be consistent with follow-up care. Use of a multi-drug regimen destroys the organisms as quickly as possible, minimizing emergence of medication-resistant organisms. Individuals with active TB should be treated for 6 to 9 months, longer if they're HIV positive. After infected individual has received medication for 2 to 3 weeks, the risk of transmission is greatly reduced. Most patients have negative sputum cultures after 3 months if they are compliant with the medication therapy. Multi-organ dysfunction syndrome is a sequence of cell damage due to release of toxic metabolites and enzymes. Once the damage starts, the sequence becomes vicious as dead cells lyse and release toxic metabolites. This results in microthrombi to form and then block oxygenation even more. 4 major organ systems involvement are pulmonary, renal, cardiovascular, and coagulation failure. Pulmonary dysfunction is a result of pulmonary vascular endothelial and alveolar epithelial damage with resultant surfactant deficiency, mild pulmonary hypertension, and pulmonary edema and hypoxia. Renal dysfunction is a direct result of prolonged hypovolemia, hypoperfusion, and acute tubular necrosis. Cardiovascular dysfunction is a result of prolonged compensation efforts to increase the cardiac output and vasoconstriction to enhance organ perfusion. During resuscitation, cardiac function becomes dependent on vasopressors and eventually is unresponsive even to those vasopressors. Coagulation system failure, uncontrolled excessive consumption of coagulation factors. The therapeutic management is to support tissue oxygenation, decrease the oxygen consumption, decrease organ system damage, control the causative agent, supplemental oxygen, and mechanical ventilation. The initial stage of early shock is that the mean arterial pressure decreases 5 to 10 millimeters of mercury and causes mild vasoconstriction. Compensatory mechanisms are so effective that oxygenation to vital organs is maintained. Non-progressive stage, which is a compensatory stage, cardiovascular compensation is no longer enough to maintain oxygen to organs. Baroreceptors sense larger decrease in the mean arterial pressure, which causes the physiologic compensation. Anaerobic metabolism causes acidosis and hyperkalemia. The cellular effects are reversible if interrupted at this stage. The mean arterial pressure could decrease 10 to 15 millimeters of mercury, moderate vasoconstriction. The physiological compensation is decreased urine output, mild acidosis, and mild hyperkalemia. The progressive stage, which is the intermediate stage, the mean arterial pressure decreases 20 millimeters of mercury. Overall metabolism is anaerobic, moderate acidosis, moderate hyperkalemia, tissue ischemia, and lactic acidosis. Compensatory mechanisms are functioning, but not enough oxygen is being delivered to vital organs. The vital organs are becoming anoxic. Some tissues have severe cell damage and die. This is a life-threatening emergency. The refractory stage is the irreversible stage. There is too much cell death, too much tissue damage, and too late to save. Renal compensation for hypovolemia is associated with reabsorption of sodium in exchange with hydrogen and potassium ions, which further aggravates the electrolyte disturbances. Increase in aldosterone causes increased sodium and water reabsorption with increases in blood volume. So to correct respiratory acid-base imbalance, the renal mechanisms will retain bicarbonate to offset the acidosis. If alkalotic, then will eliminate the bicarb. Cardiogenic shock is a state of inadequate cardiac output despite adequate intravascular volume, resulting in hypoxia. It is marked by hypotension and coldness of the skin, and often by tachycardia and anxiety. Untreated shock can be fatal. Improving cardiac output, which is necessary to improve tissue perfusion, can be accomplished in several ways. If the patient is able to maintain hemodynamic stability, then diuretics and nitrates are used to reduce the preload. A patient with cardiogenic shock is cool and clammy, and hemodynamic monitoring indicates a high systemic vascular resistance. Changes with nitroglycerin infusion will not directly increase the SVR. Dopamine may also be used in an attempt to improve contractility and cardiac output, since dopamine will tend to increase the SVR. The wedge indicates that the patient's preload is elevated, and Lasix may be given to reduce the preload and improve the cardiac output. Epinephrine would further increase the heart rate and cause myocardial oxygen demand. Normal saline infusion would increase the wedge even further. Hydrocortisone might be used for septic or anaphylactic shock. Pulmonary congestion and dyspnea are characteristics of cardiogenic shock, so the nurse should assess the breath sounds frequently. The head of the bed is usually elevated to decrease dyspnea. Nitroprusside is an arterial vasodilator and will decrease the SVR and afterload, which will then can improve cardiac output. Since nitroprusside is a vasodilator, the blood pressure may even be low, even if the medication is effective. Warm, pink, and dry skin would indicate that perfusion to tissues is improved. Hypovolemic shock. Initially, the blood pressure decreases, and it decreases blood flow to the skin, skeletal muscles, kidneys, and abdominal organs. Eventual loss of cells' physical integrity, and if untreated, will lead to multiple organ failure and death. It is caused by a decrease in intravascular volume of 15% or more. Hemorrhage is a major cause of hypovolemic shock. Plasma loss, dehydration, and interstitial fluid accumulation, like third spacing, adversely reduces circulating volume by decreasing tissue perfusion. The primary defect is decreased preload. Assessment of end organ perfusion, such as adequate urine output, is a best indicator that fluid resuscitation has been successful. The hemoglobin, the wedge, the mean arterial pressure are useful in determining the effects of fluid administration, but not useful at indicating good organ perfusion. Adequate fluid administration is essential before administration of vasopressors to patients with hypovolemic shock. A low central venous pressure would indicate a need for more volume replacement. If signs and symptoms of hypovolemic shock occur, monitor the vital signs frequently, administer the oxygen as ordered, prepare a patient for insertion of hemodynamic monitoring devices such as a central venous catheter or intra-arterial catheter if indicated. The diagnostic assessment would be to review the hemoglobin and hematocrit levels and note the trends. Decreased red blood cells can adversely affect oxygen carrying capacity. Review the lactate levels, which are an indicator of reduced tissue perfusion and anaerobic metabolism. Review the ABGs for hypoxemia and respiratory or metabolic acidosis. Review the BUN, creatinine, and electrolytes, and more trends to evaluate renal function. A palpable radial pulse reflects at least a systolic blood pressure of 80 millimeters of mercury. A palpable femoral pulse reflects a systolic blood pressure of 70 millimeters of mercury. A palpable carotid pulse reflects systolic blood pressure of at least 60 millimeters of mercury. Distributive or vasogenic shock is caused by a sudden, severe decrease in peripheral vascular resistance that causes extensive pooling of blood within the venous system and subsequent decreased venous return to the heart. Septic shock is the most common. Other causes of distributive shock include anaphylaxis, reaction to drugs or toxins, including insect bites, transfusion reaction, and heavy metal poisoning. Others include Addisonian crisis and neurogenic shock due to brain or spinal cord injury. Signs of septic shock are caused by widespread vasodilation and decreased peripheral resistance. It's caused by gram-negative or gram-positive bacterial infections. Risk factors include hospitalizations, debilitating chronic illnesses, and poor nutrition. Septic shock is any problem that impairs oxygenation delivery to tissues and organs. and it begins with an abnormal cellular metabolism that occurs when too little oxygen is delivered to tissue. Septic shock is hyperdynamic changes secondary to an inflammatory reaction to circulating endotoxins. The goal is to reverse the shock, administer oxygen, establish IV access, restore fluid volume using either colloids or crystalloids, administer blood products as ordered. Nursing assessment is pulse, the rhythm, blood pressure, check the CVP, respiratory rate, O2 sats, urine output, skin color, and monitor the labs. Nursing management includes giving 2 large bore IVs and 1,000 mL of normal saline. Prepare a patient for transfer to ICU, a stat CBC, and obtain 2 units of packed blood cells from the blood bank. Here is a patient scenario. A patient with septic shock has a urine output of 20 mL for the past 3 hours. The pulse rate is 120 and the central venous pressure and pulmonary artery pressures are low. What does the patient need? Because of the low systemic vascular resistance associated with septic shock, fluid resuscitation is the initial therapy. After receiving the 1,000 mL of normal saline, the central venous pressure for a patient who has septic shock is 10 millimeters of mercury, but the blood pressure is still 82/40. When fluid resuscitation is unsuccessful, then vasopressor drugs are administered to increase the systemic vascular resistance and improve tissue perfusion. What about nitroglycerin? Nitroglycerin would decrease the preload and further drop cardiac output and blood pressure. This is probably not what you want. What about furosemide? Furosemide will lower the filling pressures and renal perfusion further for a patient with septic shock. What about drogecodin alpha, otherwise known as Xigris, may decrease inappropriate inflammation and help prevent systemic inflammatory response syndrome, but it will not directly improve the blood pressure. What about nitroprusside or vasopressin? Nitroprusside is an arterial vasodilator and could further decrease the SVR. Because vasopressin is a potent vasoconstrictor, it may decrease coronary artery perfusion. Since patients in the early stage of septic shock have warm and dry skin, a patient's cool and clammy skin indicates that the shock is progressing. Anaphylactic reaction is caused by a humorally mediated hypersensitivity reaction. Antigen and antibody response results in an allergic response. Histamine is released, causing a massive vasodilation and increased capillary leak. Bronchial tissue involvement causes severe edema and obstruction. Risk factors include contact with the specific allergen. Because airway edema that is associated with anaphylaxis can affect airway and breathing, checking the respiratory rate and oxygen saturation are the most critical assessments. Improvements in other assessments will be expected with effective treatment of anaphylactic shock. Epinephrine rapidly causes peripheral vasoconstriction, dilates the bronchi, and blocks the effects of histamine and reverses the vasodilation, bronchoconstriction, and histamine release that cause the symptoms of anaphylaxis. Acute adrenal insufficiency is an adrenocortical insufficiency caused by damage to the adrenal cortex. It is a decrease in aldosterone and cortisol, and an adrenal crisis is a medical emergency. Acute adrenal insufficiency is caused by sepsis, trauma, stress, adrenal hemorrhage, and steroid withdrawal. Signs and symptoms mimic septic shock: severe hypotension, dehydration, hyperkalemia, hypoglycemia, hypercalcemia. To distinguish the difference, acute adrenal insufficiency shock is unresponsive to vasopressors and inotropic medications. Patient has a deteriorating mental status and experiencing nausea and vomiting. Positive inotropic agents would increase the strength of muscular contraction, like digoxin, dopamine, or dobutamine. Negative inotropic agents would weaken the force of the contractions, like beta blockers, calcium channel blockers, antiarrhythmic meds. Treatment is airway, breathing, circulation. IV fluids, normal saline, dextrose 2 to 3 liters as soon as possible. Hydrocortisone injection, 100 milligrams IV bolus, followed by 50 to 100 milligrams every 6 to 8 hours. The goal is to search for the cause and treat accordingly, like infection, low blood glucose, or high potassium. Neurogenic shock is caused by an imbalance between the parasympathetic and sympathetic stimulation of the vascular smooth muscles. Sympathetic nerve impulses controlling the vascular tone are lost, causing vasodilation. Neurogenic shock can occur following severe trauma or severe pain. The pathogenesis involves a massive autonomic nervous system discharge which disrupts vasomotor control, and there is extensive venocapillary pooling of the blood. This is bad. When all of the blood is in the capillaries, it doesn't get moved around to vital organs. Neurogenic shock is characterized by hypotension and bradycardia. Risk factors include head injuries, spinal cord trauma, insulin reactions, CNS depressant drugs, and severe pain. Patients with neurogenic shock may have poikilothermia. The room temperature should be kept warm in order to avoid hypothermia. Now, expectation or complication. A patient has an apical pulse of 58. This would be an expectation and is typical for neurogenic shock. A 25 ml urinary output over 1 hour. This is possibly a complication, but would monitor it since it's only 1 hour. Warm, dry skin is consistent with early neurogenic shock, possibly a complication. Usually with shock, the thought is fluids, fluids, fluids. The patient with neurogenic shock usually has a normal blood volume, and it's important not to volume overload a patient. Lactated Ringer solution is used cautiously in all shock situations because a failing liver cannot convert the lactate to bicarbonate. Obstructive shock is caused by an obstruction in the heart or great vessel. Risk factors are pericardial tamponade, pulmonary emboli, or aortic stenosis. In obstructive shock, cardiac tamponade requires immediate pericardiocentesis, which can be done at the bedside. Tension pneumothorax should be immediately decompressed with the catheter inserted into a second intercostal space mid-clavicular line. A massive pulmonary embolism resulting in shock is treated with thrombolysis or surgical embolectomy. This slide shows the effects of shock on hemodynamic parameters. When treating the patient, obtain the blood and urine cultures as ordered. Administer the IV antibiotics, the antiarrhythmics, aggressive IV fluid resuscitation, and assess closely the signs of bleeding, such as DIC, strict aseptic technique, fever reduction as needed, and patient family education.